Welcome to EP in Practice. Today we're going to talk about a fairly new procedure called Cardioneural ablation for vasovagal syncope. At the time of writing in 2024, this is still a fairly undefined procedure in terms of the procedural endpoints and in terms of the long-term efficacy. By and large, it's a procedure that largely targets the ganglionic plexi, which are thought to play a role in mediating cardioinhibitory vasovagal syncope. The theory is by targeting these ganglionic plexi and ablating them, we can then essentially prevent vasovagal syncope in some populations. So let's talk about this now. So vasovagal syncope is probably the most common form of fainting or losing consciousness. And broadly, there are three mechanisms of this vasovagal syncope that we can categorize the mechanisms into. Number one is cardioinhibitory vasovagal syncope. And this is where you get either sinus node slowing or even asystole. I've seen it for more than 20 seconds on a tilt table test, where a patient who's completely healthy, 25 years old, suddenly has no heartbeat for more than 20 seconds. I think the longest response that I've personally seen is 33 seconds. And this was for like a 20-something-year-old female who had absolutely nothing wrong with her. Or you can just get marked sinus slowing or sinus bradycardia like you see here. And sometimes the sinus node still fires, but the AV nodal function depresses to the point where it no longer conducts electrical impulses to the ventricle, and therefore you get asystole effectively. Vasodepressor response is where you have peripheral vasodilation, resulting in poor venous return and subsequent hypotension. So all the vessels in your leg become compliant, you get blood pooling, none of it's going to the heart, therefore none of it's being pumped to the brain, and the brain loses cerebral perfusion and you black out. And then probably more commonly is a mixture of both, called a mixed response. And this is where a patient gets some kind of cardiac response, either sinus slowing or AV block or a bit of both, but they also have some kind of peripheral vasodilation resulting in hypotension. Either way, it results in ineffective cerebral perfusion and a reduction in blood pressure resulting in a blackout or loss of consciousness. Conceptually then, cardioneural ablation, where we target the ganglionic plexi within the heart, this is unlikely to be effective for patients who primarily have vasodepressor responses. So these patients, when you get them on a tilt table test, what happens is they black out, and when they black out, you see their blood pressure tank. So it goes from a systolic of 120 to a systolic of 90 to a systolic of sometimes 40 or 50 millimeters of mercury, and they lose consciousness. But their heart rate is still 70 beats per minute, but they've got no blood pressure. So for these patients, a cardioneural ablation is unlikely to be effective, but it's postulated to potentially offer some benefit for patients who have some degree of cardioinhibitory response, particularly if they've failed conventional treatment modalities. Vasovagal syncope is usually fairly benign, and treatments are generally successful in reducing the amount of vasovagal syncope through conservative means. Generally, this means basic lifestyle changes and therapies, including counter-pressure maneuvers. So a counter-pressure maneuver might mean squeezing your legs to try and promote venous return, because as your muscles swell and contract, they kind of contract your venous tissue, and that can help venous return to the heart. The other thing is by clasping your hands together in front of you and then really squeezing your hands and pulling your arms out, and that can help try and promote some venous return to your heart in order to maintain blood pressure. So that's what a counter pressure maneuver is, and they're successful around 20 to 40% of the time in preventing syncope, depending on what observational study you look at. The other thing is that You can provide education on the signs and symptoms that precede vasovagal syncope, such as feelings of warmth and hot flushes can sometimes precede this, and then you can sit down and avoid a trigger, or lie down and put your legs up in the air to promote venous return. Avoidance of known or common triggers, so this might be specific to the patient who always has a vasovagal syncope in X scenario, or it could be a common trigger such as being dehydrated, standing for prolonged periods of time in the sun, things like that. Maintaining adequate fluid intake is incredibly important for maintaining blood pressure, and to the same effect, and contrary to a lot of other health advice for blood pressure, increasing salt intake can sometimes be beneficial to promote fluid retention and maintenance of blood pressure. So usually we're telling people to reduce their salt to reduce their blood pressure, but in this scenario, for a healthy person suffering from vasovagal syncope, we're sometimes asking them to increase their salt intake to maintain blood pressure. Compression garments like compression stockings can also be useful, particularly for example, let's say a theatre nurse who's standing for prolonged periods of time during theatre procedures, and if they have vasovagal syncopes, compression stockings can sometimes help them maintain venous return and blood pressure. Pacemaker implantations are very rarely performed, and they can be helpful. However, they're subject to a strong placebo effect. So if you tell a patient, look, we're going to give you a pacemaker to help with your vasovagal syncope, the fact that you give them a device has a strong placebo effect. And there's some evidence to say that this placebo effect accounts for much of the benefit of pacemakers in reducing syncopal episodes. Regardless, implanting a pacemaker does not always completely abolish syncope. So some patients, they might be 23 years old and they have a pacemaker now, and they're still having the occasional syncopal episode. And so is that an acceptable endpoint or therapy? It's kind of hard to say. So avoiding pacemakers where possible is generally desired. So what's the anatomy of cardioneural ganglionic plexi? The ganglionic plexi are essentially groups of nervous system which originate in the spinal cord, in the medulla oblongata, as well as a certain plexi of the vagus nerve, and then they insert into the epicardial aspect of the heart and fat pads. These ganglionic plexi carry parasympathetic input to modulate cardiac function, including the function of the AV node and the sinus node. So they can modulate and reduce the function of the sinus node, creating sinus bradycardia, and they can also increase the PR interval by promoting a slowing of conduction velocity through the AV node. Whilst they're located epicardially, they often have fibers that penetrate intramurally to the endocardium, and there's often a dense network of sensory and efferent neurons at the endocardial myocardial level. Thankfully, there is some consistency in the location across individuals of the ganglionic plexi. There is some individual variation. Some ganglionic plexi are more responsive to stimulation in some individuals, and some they're less so. Some ganglionic plexi are larger or smaller across individuals. And it's important to point out that during an EP study, we can't see the ganglionic plexi. We can't see them as a structure. So we can only infer and presume their location based on a number of techniques, and those techniques aren't really well defined in the industry. So the locations of the ganglionic plexi are the superior right atrial ganglionic plexi, and this is a ganglionic plexi that's located at the SVC to right atrial junction. There's the superior left atrial ganglionic plexi, which is at the anterior roof portion of the left superior pulmonary vein. And this is why when you perform a pulmonary vein isolation ablation, often you get some vagal response or innervation when ablating in this region. And that's largely because of you're affecting the ganglionic plexi during endocardial ablation. There's the posterior right atrial ganglionic plexi, which is not pictured here. It's sort of behind the right inferior pulmonary vein here, and it would be expected to be in the right atrium around this region. There's the posterior medial left atrial ganglionic plexi, which is this ganglionic plexi location here, which is on the inferior right aspect of the posterior wall, near the antrum of the right inferior pulmonary vein, perhaps just a little bit inferior to the inferior pulmonary vein. There's the interatrial septal ganglionic plexi, which sometimes requires biatrial ablation in order to effectively ablate. And then there's the posterolateral left atrial ganglionic plexi, which is just posterior and inferior to left inferior pulmonary vein near the posterior wall. You'll notice that we probably ablate at least partially some of these ganglionic plexi during our routine AF ablations, although that is not the purpose of this procedure. We'll get to the specific techniques of cardioneural ablation in a moment in terms of procedural techniques, but I just want to take a moment to look at how effective is it based off the observational data that we have for dealing with patients or helping patients who have cardioinhibitory syncope from a vasovagal response. So specifically for patients who exhibit a V block during the cardioinhibitory vasovagals, cardioneural ablation seems somewhat effective. So these authors here, they took 31 patients who had demonstrable AV block mediated vasovagal syncope, and they targeted the ganglionic plexi, and they continued to target the ganglionic plexi with radiofrequency ablation until they eliminated the vagal response to ablation. So when you ablate these regions, you get a vagal response where the heart rate slows, and so they kept ablating these regions or these anatomical locations until they stopped getting that vagal response, surmising that that meant that they ablated all that they could of the ganglionic plexi and had abolished it. They also continued to ablate until they had an abolition of a response to atropine, which means they've successfully denervated the heart to the point where providing atropine to the patient does not significantly increase their sinus rate or reduce their PR interval. So those are the procedural endpoints that they used, and for most patients, 28 out of 31, they required biatrial ganglionic plexi ablation, but there was a few patients who only required right-sided ganglionic plexi ablation. Now this is relevant because biatrial or left-sided ganglionic plexi ablation requires left-sided access, which increases stroke risk and transeptal puncture risk and a number of things like that, which is of course a significant risk in an otherwise healthy patient. The authors noted that the most important ganglionic plexi to ablate was that posterior medial left atrial ganglionic plexi, and that was the critical target for denervating the AV node and abolishing its response to atropine. In an almost 2-year follow-up, most patients who had this ablation didn't have recurrent syncope. However, 2 patients did have syncope and they eventually required a pacemaker, but that wasn't due to complications from the procedure, but rather for continued vasovagal mediated AV block. For patients who exhibit primarily a sinus slowing vasovagal syncope,